Hi, everyone. Thanks so much for joining us. Sorry for the mix-up about the Zoom link, but I'm really glad that you found us. And we're just going to wait a few more seconds until everyone comes in from the waiting room. Okay, I'm going to get started. Thank you all for joining us today for an important spontaneous webinar. And thank you, Dr. Tanner, for your willingness to participate in this webinar, despite such a short timeline and practically no advance notice. I think it's safe to say that all of us in this virtual room right now are alarmed by the new clinical guidelines for the evaluation and treatment of obesity of children and adolescents. As soon as I read the guidelines, I knew F.E.A.S.T had to react, and I gave a lot of thought as to how we should do this. I landed on this webinar. F.E.A.S.T is known for our principles of community and education, so it felt right to me to address this issue through education as a community. Though it was the American Academy of Pediatrics that released the concerning new clinical guidelines, this is not an American issue, and Dr. Tanner will be presenting information which is applicable to all parents and providers, no matter where you live. Before I introduce our speaker, I'd like to ask you all to please check that your cameras and microphones are off, and please keep them off throughout the webinar. If you have a question for Dr. Tanner, please put it in the chat box, and we'll get to it at the end if we have time. Dr. Tanner is Vice President of Child and Adolescent Medicine for Acanto Health with Brands Veritas Collaborative and the Emily Program. She is a board-certified pediatrician who has specialized in the care of complicated adolescent patients, in particular patients with eating disorders, for almost 25 years. Dr. Tanner has been very involved in advocacy and education efforts and serves on national and international committees for eating disorders education. She speaks frequently across the United States on medical complications of eating disorders, especially as they affect children and young adolescents. Dr. Tanner currently serves as an adjunct assistant professor of pediatrics for Emory University School of Medicine and as an adjunct clinical assistant professor in the Department of Psychiatry and Behavioral Science for Morehouse School of Medicine. She is co-chair of the Academy for Eating Disorders Medical Care Standards Committee and a member of the International Association of Eating Disorders Professionals Curriculum Committee. Dr. Tanner is a fellow in the Society for Adolescent Health and Medicine, a certified eating disorder specialist, and a certified eating disorder supervisor. She has been named by Atlanta Magazine as a top doctor every year from 2013 to 2022, and named by Castle Connolly as an exceptional woman in medicine and one of America's most honored doctors. It is our honor to have Dr. Tanner with here today. Thank you, Dr. Tanner.
Thank you, Judy. All right. Very happy to have this time with all of you today. Let's see if we can get my screen up. Can y'all see my presentation? Okay.
Yes, we can see it.
All right. Unfortunately, I lost my little prompt screen. Can you guys bear with me while I restart this whole process? Hold on. One second. Sorry, we changed slides around a little bit and that made all of my screens move. So my apologies, everybody. All right. Is that working now for everybody okay?
We can see the slides.
Great. Okay. Well, again, Judy and F.E.A.S.T, thank you so much for having me today. Excited to be with you all. Wish it was under different circumstances. And again, thank you too for the disclaimer, Judy, that we kind of put this together pretty fast. I also should add that I'm not only a fellow in the Society of Adolescent Health and Medicine, but also a fellow in the American Academy of Pediatrics. So it's really important to me that we have this conversation today. So here are our goals. The first thing we're going to do today is we are going to discuss these new American Academy of Pediatric guidelines. Our second part of the agenda is we're going to talk about some of the responses so far to date on the guidelines. Just a disclaimer, not all of them, but a few of them. And then we're going to talk a little bit about next steps for parents and providers. And as Judy said, we'd like to have some time for some questions and comments at the end. So hopefully I'll time things pretty well that we're able to do that. So as Judy mentioned, this has been in the news. These new American Academy of Pediatrics guidelines are all over the news. Even just this weekend, if you do a quick search, all of these news outlets had something on this topic in just the last few days. So there's a lot of discussion about these guidelines. Now, before we discuss the guidelines at all, I do want to make a disclaimer. Okay, so the guidelines we are discussing are the American Academy of Pediatrics guidelines on the treatment of obesity. So we are going to be using the term obesity, and I'm using it in here in quotes, throughout this presentation. And I am very aware that this term, just this word, has a lot of negative and pathologizing connotations for many persons. I really am going to try my hardest to use in this talk this word only as it relates to the specific criteria and medical terminology. Personally, I prefer to use terms, any other term than this term. So please know that that is my personal preference. And yet when we're discussing the literature, we're going to use the words in the literature. You will see me use quotations a lot in this presentation. We will also, unfortunately, have to use the term severe obesity, which is included in the AAP guidelines. This term has additional stigmatizing risk. I'm very aware of that. And again, we're going to try and limit our use of that term specifically to the criteria related to medical terminology. So I hope that I'm explaining that well as a disclaimer up front. There will be some additional terms used in this presentation that will directly be used from either terminology in the AAP guidelines or terminology used in the discussions regarding the AAP guidelines. And as I mentioned, you will see me use quotations a lot in the slides for this presentation. So let's start talking about these guidelines. So what do we even mean when we say the AAP guidelines? So actually, there are 4 parts to the guidelines. It is actually a massive publication. So the first part, the part that most people saw early on when it was released, is called the Clinical Practice Guideline for the Evaluation and Treatment of Children and Adolescents with Obesity. We'll talk a little bit about it. There is also an accompanying executive summary. We're going to talk about what that document includes. And then there are 2 technical reports. There is one technical report focusing on interventions and a second technical report looking at comorbidities. So that first part, the part most people have been discussing, that's called the Clinical Practice Guideline. This is a massive publication. It is 100 pages long. So if you are going to print it out to do a detailed review, you will have to load up your printer with paper before you even get to it. It includes 801 references. There are 21 authors on this paper. 14 of those are fellows in the American Academy of Pediatrics. And this paper was released online in the Journal of Pediatrics on January 9th as part of the February 2023 issue. The second part of the publication is called the Executive Summary, and the Executive Summary is a much shorter publication. It's really important that people understand what this publication is. It's very short. It's only 9 pages. It only includes 46 references. It also has 21 authors, 14 of whom are fellows in the AAP. It too was published online on January 9th, but it was printed in full in the February 2023 print edition of Pediatrics. And we'll talk a little bit about this, but remember that for pediatricians who are getting it in the mail, this is the version they are going to have in their hands. And this really affects some of the conversations. We're going to talk about what that means. I also want to cover just very briefly the two technical reports. They are also quite extensive. The first one had a key research question, which was, quote, what are clinically based effective treatments for obesity, end quote. And the second one had a research question of, quote, what is the risk of comorbidities among children with obesity, end quote. The first one, very large, 237 references. The second, also a very large publication, 171 references. And again, both of these very detailed papers were only published online. They were not published in the print issue of Pediatrics. So 4 parts to the guidelines, one part in the print edition. So let's talk a little bit now. You kind of understand how big this publication is. Let's talk a little bit about what it said and the parts of what it said that everybody's focusing on. So the 3 big parts that everyone is discussing. Number 1, this guideline included a recommendation for behavioral weight loss programs for children and adolescents beginning at age 6 and up. There was also a recommendation for prescription weight loss drugs for children and adolescents starting at age 12 and up. And lastly, this guideline included recommendations for bariatric surgery for adolescents starting at age 13 and up. There are a lot of reasons why this is concerning, but 2 of the ones that I want everybody to be very aware of and listen for as we go through more detail is all of this is based on BMI percentiles. And this executive summary is a shortened version. It's the version that came out in print, and it lacks significant nuances, including things like screening for eating disorders. So the fact that there's 4 parts to this publication, it's all based on BMI. There's the short version, there's this long version. There's a lot going on with this publication that should be discussed. So the executive summary, the short version, the print version, what did it say? It made some assertions for pediatricians besides these treatment recommendations. It said that pediatricians should coordinate evaluation and treatment of obesity and related conditions. And you can see I've got a quote right there from the paper. Additionally, the executive summary stated that pediatricians should think of this as a chronic disease. And in fact, a quote from that was that obesity is a chronic disease with multiple complex contributing factors. The factors that the executive summary listed were socio-ecological, environmental, and genetic. And lastly, the executive summary stated that pediatricians should provide a medical home, that this would follow a chronic care model, and that they should do so in a manner that is family-centered and not stigmatizing. So this is kind of the crux of the executive summary, is to have these recommendations, but also kind of to put it in this frame. When they, after framing up the conversation, both the executive summary and the full practice guideline have these 12 key action statements. So these are the statements that the American Academy of Pediatrics that they're putting forward as actionable items. They're included in both of those publications, and these are where a lot of the discussion is centering on these key action statements. The research, those 2 research papers that I told you about, that is where a lot of the research sits behind these recommendations. But as we'll discuss, most of these recommendations are a research grade B or a research grade C, meaning those are lower grades of research, and yet they're still feeling like they are strong enough to make these key action statements. And I'm not going to read all 12 of them. There's a lot of detail here, and I kind of whittled down the key action statements for all of you. But of concern to me are 5 in particular. The first is that all children aged 2 to 18 with a BMI greater than or equal to the 85th percentile need to be screened for obesity-related comorbidities. The second that I highlighted for you is that children 10 and older with BMI percentiles in the same range should get screened for glucose, liver, and lipid abnormalities. So this is recommending blood tests in children as young as 10 in this BMI percentile. There are additional recommendations about screening for diabetes, non-alcoholic fatty liver disease, high blood pressure, and lipid panels with a lot of detail in there. And then the final 3 key action statements are the ones that we started with and that are getting a lot of discussion. So the first is that children 6 and older who have a BMI percentile greater than equal to the 85th percentile should be involved in behavioral health treatment. And there is a caveat that you may refer children as young as 2 to 5. Second recommendation in these key action statements, it's getting a lot of discussion, is this one that children 12 and older with a BMI greater than the 95th percentile should be offered weight loss pharmacotherapy. And the third discussion point for many of the conversations that I've been having is this recommendation to offer adolescents 13 and older with a BMI that is greater than or equal to 120% of the 95th percentile metabolic and bariatric surgery. As I've mentioned, if you look at either the executive summary or the clinical practice guideline, you will see that these recommendations are based on grade B and grade C research evidence. Additionally, the authors listed a set of consensus recommendations. So these recommendations are not backed by research evidence. And there are additional recommendations in here. I'm not going to go through them at length, but this is where you'll see the last bullet point I've highlighted for you. This is where the authors included that children age 8 through 11 could be offered weight loss pharmacotherapy. So if you have seen that in some of the discussions, that's where this sits. So I just want to be clear, it is not in one of the key action statements where it is backed up with any research graded recommendations. It sits here separately. So some details related to very young children. I just want to make sure you all caught this information. In those key action statements, they are recommending evaluating children every year at every visit, starting at age 3, if their BMI is greater than or equal to the 85th percentile, and that they're recommending behavioral therapy starting at 6 for that same percentile, and offering that children as young as 2 to 5 can be offered behavioral therapy as well. And then, as I really highlighted for you, those consensus recommendations, they have the statement that children 8 to 11 can be offered weight loss pharmacotherapy as an adjunct to health behavior, what they call health behavior and lifestyle treatment. These are very, very young patients that we're talking about in this set of guidelines. So I want to talk about those 3 most controversial areas, just to kind of go back, these big 3 here: behavioral therapy, the weight loss pharmacotherapy, and the bariatric, metabolic and bariatric surgery, kind of what was included in those documents. So the first is regarding behavioral weight loss programs. So this policy states that the goal of this treatment is to help the child and adolescent and the family change lifestyle, behavioral, and environmental factors, that providers should use motivational interviewing as a core component of engaging these programs, and that for patients, like we said, 6 and older, that pediatricians and they make it very clear, other healthcare providers who are taking care of children can use an intensive health, behavior, and lifestyle treatment program. That's what that IHBLT stands for. They recommend referring children 6 and older, considering referring children age age 2 to 5. And they detail in the paper that these programs should include 26 hours of treatment over 3 to 12 months. That's kind of the minimum that they consider effective. But they go on to say in the executive summary that if one of these programs is not available, then pediatricians should just provide the most intensive program possible with their available community resources. So obviously, that is one of the statements of concern in these guidelines. Now, when you get to the longer article, there's more information in there. And so I want to talk about some of the details that are in the longer article that didn't make it to the executive summary. The full length article acknowledges that there's a risk of disordered eating patterns developing when we pay attention to eating habits and body shape and body size. So that's in the longer article. It's not in the executive summary. There's also a discussion that self-guided dieting can place children at high risk for weight fluctuation and disordered eating. And the full-length article acknowledges that there is limited evidence for durability of weight change after treatment. So you've probably seen a lot of commentaries on the concept of, we used to call yo-yo dieting. So some of this is acknowledged in the full-length article, but again, not in that executive summary. Additionally, in the full-length article, they talk a little bit more about motivational interviewing, and they tell primary care providers that behavior change is the patient and the family's decision, not the pediatrician's. Again, this is not included in that shorter executive summary, but for an organization like F.E.A.S.T, this is a really important comment to note that got included in the long article. Also, in the long article, there's a much more of an acknowledgement of these behavioral programs. There were many, many comments about them. I grabbed a few that I thought would interest this audience. One comment acknowledged that of the studies reviewed, 23 of the low-intensity studies were not effective, that limitations included the scarcity and distributions of treatment programs like this. And one of the other comments was that in research settings, attrition rates of 40% are common. So patients are dropping out of these programs at rates of 40%. So these are things, again, not acknowledged in that shorter executive summary, the print version that pediatricians got in their hand, but they're acknowledged in the longer paper. Now, when we talk about that second recommendation, where there's been a lot of discussion, the recommendation for pharmacotherapy. So again, let's kind of start with the short article, the executive summary. What was recommended? What did it say specifically? It said that pediatricians and other primary healthcare providers should offer adolescents 12 and older with obesity, weight loss pharmacotherapy, and that should have been in quotations there, as an adjunct to health behavior and lifestyle management. Additionally, the executive summary says that pharmacotherapy is an adjunct treatment to specifically improve weight loss outcomes. So that is in that executive summary. And the executive summary also states, we've mentioned this before, that providers can offer children 8 to 11 weight loss pharmacotherapy as an adjunct to health behavior and lifestyle management. So some concerning statements there for sure. It's not until we get into the longer article, again, that we get more details and more acknowledgments. So in the longer article, where it states that pediatricians and other healthcare providers can offer kids 8 to 11 weight loss pharmacotherapy, there's an acknowledgement that for children younger than 12, there is insufficient evidence to make it a key action statement. Okay, so they're actually saying in the longer article, we actually don't have enough evidence to make this a key action statement. I think that's really important to acknowledge. The long article has an extensive discussion of pharmacotherapy, and it states that providers can consider pharmacotherapy with a pretty extensive list of medicines. Medicines that are discussed in this paper include metformin, orlistat, the group of glucagon-like peptide-1 receptor agonists, medicines that we are more used to seeing in patients with diabetes, phentermine, topiramate, and the generic Vyvanse is discussed as well. And in the longer article, there is a statement that there is no current evidence that supports weight loss medication as a monotherapy. This is not a stressed statement, but it's in there. Okay, so we've got one last part of these recommendations that we should discuss, and that is this recommendation for bariatric surgery. So again, we're going to go back to the short version, the executive summary, what treatment was recommended. And again, I've got it in quotes on this one: pediatricians and other healthcare providers should offer referral for adolescents age 13 and older with severe obesity. This is the term they use for evaluation for metabolic and bariatric surgery to local or regional comprehensive multidisciplinary pediatric metabolic and bariatric centers. So they've got a lot of descriptors in that statement. And I want to be clear that in this summary, what they are recommending, their cutoff for this, is adolescents with a BMI that is more than 120% of the 95th percentile for their age and gender. So more on that to come. We're going to come back to that in a minute, but remember that descriptor. The longer article, the full article, acknowledges a couple things about this. First is that all of the research uses specialty programs, right? So that any studies that we have suggesting that weight loss surgery, again, quote should be there, is safe and effective for pediatric patients was done in comprehensive metabolic centers with extensive experience working with youth and their families. So I think that the nuance of that, again, it only shows up in the longer article. Also, only in the longer article do they include a discussion of complications from surgeries such as this. So they do acknowledge that there are major perioperative, that means around the time of surgery, complications in 8% of individuals. They acknowledge that 13 to 25% of patients will need additional procedures, 13 to 25%. They do acknowledge that there is data out there that shows multiple micronutrient deficiencies following surgery. And they do acknowledge that patients who have this surgery need routine and long-term monitoring because of the risk of these nutritional deficiencies. And again, this is a discussion that does not take place in that short executive summary. It is only in the long paper that you will find this discussion. Additionally, risks are discussed, but not until you get to the long paper. So they acknowledge several risks. We're going to talk about 5 of them. The first is they do acknowledge the risk of dieting. So they acknowledge that with these guidelines, patients are at risk of self-guided dieting, which puts children at risk for weight fluctuations and disordered eating. They do acknowledge in their discussion on comorbidities that we don't actually have research on this, that there is a need for more studies before we can reach definitive conclusions about whether evaluating families for comorbidities increases engagement and adoption of healthy choices and weight loss, or if it in fact has unintended negative effects. So again, this is in the long paper, but not in the short version of the paper. So they have a very long discussion about comorbidities, and comorbidities are discussed in both papers, but it's only in the long paper that they say we actually don't have enough research to know if this can have negative effects. Regarding discussions around weight, again, only in the long paper do the authors acknowledge that discussions regarding weight can elicit strong emotional responses, including sadness or anger. And there's some discussion of weight bias and the use of BMI, again, in the longer paper. So with regard to weight bias and weight stigma, these are the acknowledgements that the authors made in the full-length guideline. The authors state that pediatricians, quote, have been and remain a source of weight bias. This is stated in the full-length version of the article. And it states that pediatricians must acknowledge this and reduce this to have productive conversations and improved relationships. And this is a really important feast that I would like F.E.A.S.T and their friends to focus on, because this is acknowledged in the long article and not highlighted in the short version. We all know that weight stigma can contribute to binge eating, social isolation, avoidance of healthcare services, decreased physical activity. These are very significant complications that could be avoided. We know that internalized weight bias can have a very negative impact on mental health. And we know that all of these factors together can actually keep patients from seeking medical care at all, which may in fact worsen morbidity or mortality. So this is kind of acknowledged, but we know that it is more than this, the results of this weight bias. Additionally, there is a discussion in the full-length paper about the decision to use BMI. There's a significant discussion, and the limitations of BMI are acknowledged, and then they use it anyway. So they do acknowledge that BMI is not a direct measure of body composition. They do acknowledge that it can over and under detect concerns, especially in certain racial and ethnic groups. And they do acknowledge that children and adolescents may be incorrectly classified by the use of BMI. And yet it is chosen for all of the recommendations in in all of the subparts of this paper. They do discuss that BMI percentiles are calculated from the CDC growth curves. Those CDC growth curves date to the year 2000, and they're based on population data that come from the 1960s through the early 1990s. And we know that the percentiles on growth charts now do not equate to the current population. So there's a discussion of this. It's acknowledged in the full-length paper, and yet it is what these guidelines are based on. They do discuss that they are not using BMI Z-scores. BMI Z-scores are what we use in the field of eating disorders. That is how we assess malnutrition. It's how we assess the risk of refeeding. We make a lot of decisions about severity of illness for patients with eating disorders using BMI Z-scores, and yet they're not used in these guidelines at all. There is no discussion in either version of the paper about the impact of differences on growth and puberty. And those of you who know me know this is my wheelhouse. Children are growing and adolescents are in puberty. And when that's not happening because of eating concerns or nutritional concerns, it's our job as providers to help figure out what is going on. And that is not discussed in this article. There is also not a discussion of the new CDC growth curves, but if nobody noticed it, I did, and I'm going to show you. The CDC published extended growth curves on December 15th, 2022. You can look them up. They are available on the internet as open access. So the CDC created these quote unquote extended growth curves, and they are BMI for age growth charts for what the CDC calls higher BMIs. As I said, they were released on December 15th, and they contain a line that highlights the 120th percent, 120% of the 95th percentile. So the curve I'm showing you in this slide, to the left, the green is boys age 2 to 20, and on the right is girls in yellow, age 2 to 20. You'll see those bands that are augmented color, and you will see that there's a dark swooping line running across those bands, and that is that 120th percentile. And you will remember that the AAP guidelines recommend bariatric surgery referrals at that 120th percentile. So the CDC has published a new growth curve that highlights that line. And I have not seen any discussion on this yet, but I would like FE.A.S.T to be aware of this and parents to be aware that these are out there. Structural factors are addressed in both papers, but briefly. They acknowledge that there are socio-ecological, environmental, and genetic factors that contribute to these concerns, that there are systemic challenges that cause inequities, that may maintain health disparities. However, all of the interventions focused on in these papers are individual interventions. They don't address any structural barriers in place. They put the full responsibility of solutions on children and their families with their providers to come up with individualized solutions. And so this is one of the areas that you will see in a lot of the comments that there's been a lot of focus on this. Additionally, we just got to say, the risk of eating disorders is not fully discussed. Only in the full-length paper are eating disorders mentioned. It's not mentioned in the shorter version, the executive summary. In the full-length paper, they do acknowledge that the prevalence of eating disorders is not well characterized in patients participating in obesity treatment, but these patterns may be more common. They advise pediatricians to evaluate patients before, during, and after intensive behavioral intervention for the presence of disordered eating. And this paper refers to the 2021 AAP report on eating disorders, but they give a very narrow focus. They tell providers to look for abrupt changes in BMI, loss of menses, changes in vital signs, and we all know that eating disorders can present in many other ways. They're much broader than that. And also, there's no discussion of what pediatricians should do if an eating disorder is suspected. Additionally, the full-length paper refers to the 2016 American Academy of Pediatrics report on prevention that states that adolescents with obesity may engage in unhealthy practices to lose weight, and these practices include skipping meals, using diet pills, laxatives, and inducing vomiting. So they're acknowledging these concerns, and yet this is only in the long version of the paper. So I want to talk for a minute a little bit about some of these prior statements. We know that the Academy of Eating Disorders, the Society of Adolescent Health and Medicine, the Academy of Pediatrics have put out a lot of prior statements. And some of the key things you will see that I'm featuring are we shouldn't conflate weight and health. They are not the same thing. Individuals can be malnourished at any weight. Adolescents may and can and do experience weight stigma from healthcare professionals. Patients with eating disorders, many patients have a history of being at higher weights. We have also said in the past that providers should not promote dieting, they should promote positive body image, and that we should not train families to talk about weight. So I just want to cite a couple other publications that all of you can be aware of and cite. So the first is this is the Purple Book from the Academy for Eating Disorders. The Medical Care Standards Committee writes this. The 4th edition came out in 2021 during COVID. But in this, we state that excessive value placed on weight loss, as well as conflation of weight and health by providers and society, can delay eating disorder recognition and treatment, that individuals at any weight may be malnourished, and that malnutrition is a serious medical condition and it requires urgent attention. So all of that can be found in the AED Purple Book, and that's available online. That's a free resource and you can print it out. In SAM, the Society of Adolescent Health and Medicine, just last year in the fall, they published their new position paper on the medical management of restrictive eating disorders in adolescents and young adults. And they point out that patients may have moderate to severe nutrition despite normal BMI. So BMI is not the marker of nutrition. And that increasing proportions of adolescents and young adults have what we now define as atypical anorexia nervosa. They may be of normal weight, but they can have life-threatening complications, especially after rapid weight loss. And I want to point out that in this publication, we have a chart of a proposed classification of malnutrition. And you can see that rapid weight loss is a criteria for severe malnutrition. Again, going back to the AAP's own publications, they had their own report on eating disorders, managing eating disorders, that came out just in 2021. And in this paper, the Academy of Pediatrics said that adolescents with larger body habituses are exposed to weight stigma through media, family, peers, teachers, and healthcare professionals, resulting in depression, anxiety, poor body image, social isolation, unhealthy eating behaviors, and worsening obesity. Additionally, in the same paper, the AAP said that recognizing many patients who present to eating disorder treatment programs have previously had elevated weight, They said it's worthwhile to carefully inquire about eating and exercising patterns when weight loss is noted. And they said that screening for unhealthy and extreme weight weight control measures should, before praising desirable weight loss, can inadvertently reinforce these practices. Forgive me, that was a lot of quotations to read on the screen, but I want you to see how much is out there. Lastly, this paper is a huge departure from this. This is the 2016 AAP preventive report. So this is what the Academy of Pediatrics said just a few years ago. They said we should discourage dieting, encourage family meals, promote positive body image, and encourage families not to talk about weight. So this is one of the reasons that this paper has caught so much attention, because it is such a big departure from their last publication on how we would prevent concerns. So I want to take a minute to go over some of the concerns from the eating disorders field. Many of the concerns center around the promotion of weight stigma, the increasing eating disorders, focusing on weight management as an issue of personal responsibility and action. There was an excellent statement that came out from the International Federation of Eating Disorder Dietitians. I won't read it in its whole, but they said that we should promote weight inclusive treatment and not pathologize body size, and that pediatric dietitians should be used if there's ever a concern about a child's nutrition. And they said, as healthcare professionals, we cannot condone pathologizing children whose growing bodies are deemed quote unquote too large. Additionally, F.E.A.S.T pointed out they were very disappointed that dietitians were only mentioned very briefly, and they are only in the full-length version of the report. They feel very strongly, and I agree, that a full nutrition assessment is needed to determine if eating changes are warranted. And the paper itself acknowledges that most pediatricians are not going to have time for this critical step, but it's not emphasized. They are also very concerned about the lack of consideration for these social determinants of health that they're mentioned and not addressed. And they did acknowledge, though, that some pediatricians do a good job providing individualized care and things that they think are good that pediatricians do when they consider all aspects of health, quote, independent of size, when they support patients by screening for dysfunctional eating behaviors, and when they make recommendations that are based on the best interest of the whole child. So this is a great paper to take back to pediatricians and say, this is something professionals feel like pediatricians can do to do a good job. The Collaborative of Eating Disorders Organizations also offered a statement. They very strongly said that they don't support intentional weight loss in children by any of the methods included in the guidelines, but especially the recommendation for bariatric surgery and pharmaceutical products. They also went on in their statement to make a couple other really important points. Again, they stressed that these guidelines talk about complex factors such as social determinants of health, but all of the interventions are based on individual changes. They made a great point, and this is a good point for F.E.A.S.T, that children are going to look to their parents to mediate interactions with medical professionals. And the new AAP guidelines may allow parents to listen to harmful advice. So this is a really important point that we are going to have to find a way to stress and navigate. I have some thoughts, and we're going to get to them in a minute. And then lastly, they obviously encouraged the AAP to reconsider the guidelines, as did F.E.A.S.T. Lastly, at the end of last week, the Academy for Eating Disorders did offer their comments. They stated very simply that this paper is a major shift from the prior 2016 AAP recommendations, and I showed those to you all. We've discussed them a bit. They asked the AAP to revise the guidelines and to get input from eating disorders professionals, as well as individuals and families with lived experience. And they cited to the Academy of Pediatrics that the Hippocratic Oath says for all physicians to first do no harm. It's a really important statement, again, one that we can all hold on to. Some additional concerns from the Academy for Eating Disorders, they made three main points. One is that the guideline only makes minimal reference to screening for eating disorders and referring for treatment. We mentioned that before, and the AED the statement really focuses on this and how lethal eating disorders are, how early detection and treatment are so critical to recovery. There's no course identified if a provider is concerned that an eating disorder might be present. Secondly, the AAD points out that the paper keeps saying that pediatricians should approach the topic of weight with sensitivity, but they are concerned that, quote, traditional medical training minimally equips healthcare providers with these skills. And again, circle back to this point that weight discrimination is associated with internalized weight stigma and poor mental health, that focusing on weight loss can harm some individuals, and we don't know enough about eating disorder risk factors, so it's very hard to predict who may be harmed by these recommendations. These are great points. Additionally, the AAD pointed out that they have a lot of concerns about long-term efficacy and safety of medicines and surgeries. Other concerns from the eating disorders community at large, a lot of conversations on this discussion of weight over health, lots and lots of concerns that these recommendations could increase eating disorders prevalence, lots of concerns about the risk of malnutrition and impaired growth and development. As I mentioned, this is not even covered in the paper. Concerns specifically around pharmacotherapy, things that have come up. It's worth mentioning that once started, many patients require a lifetime of medication use, so this is concerning. There's no long-term safety data for many of the medicines that are discussed. There are no long-term studies of the effect of these drugs on youth and on their brains. And there is a concern that's been raised on how independently we can even research these things, independent from the pharmaceutical companies. As far as the recommendations for bariatric surgery, concerns in discussions include that these surgeries require a lifetime of strict diet and exercise guidelines. There's a risk of micronutrient deficiencies, gastrointestinal complications, and we know that eating disorders can emerge after bariatric surgery. A small hope for next steps. Jenny Thomas sent this letter to all of the everyone who is in the Academy for Eating Disorders, that the American Academy of Pediatrics has read our statement and have agreed to meet with the Academy for Eating Disorder leaders, and those talks are already underway. So we are getting some interaction with the Academy of Pediatrics to discuss these guidelines. So next steps, what can everybody on this call do? I have some thoughts. We can all work to educate pediatricians. We can advocate for our children. We can advocate in our communities. And I have a couple additional thoughts about navigating the guidelines. I'm just going to take a couple minutes to walk through those, and I think we'll still have some time for some questions, Judy. So first, as far as educating pediatricians, this concept of weight stigma and weight bias should be discussed, okay? Pediatricians need to understand that weight stigma can play a role in the development of eating disorders, and it can have very negative consequences: depression, anxiety, poor body image, social isolation, unhealthy eating behaviors. They need to understand this, and they need to understand, and it's cited in the article, that they may be a source of weight bias, and they have to do their own work and address their own attitudes before they can do anything with this topic. And so this is a really important point that we are going to have to work on with pediatricians. When it comes to advocating for our own children, there is a section on communication, and I want to stress that in the full-length version of the article, the authors identify 3 key factors as important in communication in these conversations. And the first is they tell providers they have to ask permission to discuss the patient's BMI and or weight. And so I really want to call that out. They have to ask permission. They are not supposed to do anything else until they do that first step. This is something I think we can really lean into. They also identify that you have to avoid using any labeling terms, and that for these discussions, when they happen, any words used should be perceived as neutral by the parents, the adolescents, the children involved. This long version, the full version of the paper, also states that even in the best of circumstances, or when done well, I can't remember how they describe it, that these discussions can elicit very strong emotional responses, including sadness or anger, and providers have to be prepared to acknowledge and validate those responses. So these are, again, things that we can take back and use as forms of advocacy for our children, and they come from the paper itself. So we should really lean into all of this. It's in the paper. We need to call it out. As far as advocating in our communities, so much work to be done. We all know how many barriers there are for good health in so many areas of our country and worldwide. All of us can work to identify and address systemic challenges and inequities that are causing and maintaining health disparities. And one huge factor, of course, is access to nutrition and counseling services, which is not enough of those services. And that is one thing that all of us can do, all of us can work on to try and improve access to care. These are my thoughts on navigating the guidelines, besides all of the things I've mentioned so far. I think it's okay for all of us to work to redirect the conversation to health. This is the old stance of the Academy of Pediatrics. Conversations should be about health, not weight. They are not the same thing. And if you want a citation on it, you have that AED purple book you can grab. All of us would probably agree we need to spend more time prioritizing health promoting behaviors. And what are some of those? Joyful movement, adequate sleep, a variety of nutrient dense foods. These are conversations we can be having. These are behaviors we can be promoting and focusing on. I pointed it out that it's in the full length article, but I'm going to say it again. If you do not want to discuss these topics in front of your child, parents should tell their pediatrician, and pediatricians should listen to that. And it's in the full length guideline. It is there, and we have got to make sure that this is enforced. And if you feel like you should, if you need to, you should talk to an eating disorder specialist or weight neutral provider. If you need second opinion, validation, questions and concerns, providers are out there and we should access them as needed. So that's the end of my prepared comments and discussion on the proposals. So I think what I'm going to do next, Judy, is exit my slideshow and let you take back over. Would that be good?
Perfect. Thank you very much.
Okay. All right, gotta see if I did it correctly. How'd that go?
Yes, you did. You're good. Thank you. Okay, so the first question, which actually is interesting because I wanted to ask this too, which is, are there any caveats for kids who are born at the 85th percentile or greater? Wondering where growth charts might be used, if at all, with pediatricians' use of these guidelines. And on a personal note, my son was 11.5 pounds when he was born. So he basically started out of the gate. You know, like he would have been recommended for medication and surgery, you know, like when he was an hour old. So this question kind of was close to my heart because I know that it really happens.
Yeah, and so I did point out that an extensive discussion of growth and development is lacking from this paper. Kind of general basic pediatrics. We know that children's growth from ages 0 to 2 is actually quite independent from their growth to 2 to 20. So typically as pediatricians in the United States, we plot infants on the WHO growth charts up to age 2. And then at 2, we switch to the CDC growth charts. And there are variations on this around the world. You will see different growth charts used, but it is a pretty common standard to look at growth from 0 to 2, very independently from 2 to 20. So that is probably one of the reasons why a lot of these recommendations center around 2 to 20. There was a caveat noted, I believe, in the full length version about looking at children under 2 separately. So just be aware that that is mentioned in the full length version of the article. Remind me the second part of the question, Judy.
Just where growth charts might be used.
Yeah. Yeah, so that is why I included those new growth charts, because I was not aware they were out. And one of the things that is mentioned in the articles is advocacy for electronic medical records, to include growth charts, to include prompts. And so I think this is something that we're all going to need to be aware of. It may be an additional advocacy opportunity, Judy, for many of us that are friends of F.E.A.S.T, because I am very concerned about this new growth chart with just a dark line where kids are going to get a single point above the line and off they go, and below the line. I find it very concerning that that growth chart is out there, to make it easier to calculate when kids have crossed that dark line. So I think, like I said, it's so early in the process of kind of processing all of this. I really just wanted your audience to be very aware of what we knew was out there at this time.
Thank you. A really, really good question. How do we as parents help to educate pediatricians and advocate for our children in a way that will be well received by pediatricians? Because many of us as parents have found that individual pediatricians might feel attacked or put on the spot by a parent, bringing forth these guidelines. It's not usually well accepted.
Yeah. I mean, I do think it might be worth even thinking about creating a resource, Judy. But like I said, the full-length version of the article tells pediatricians and primary providers they have to ask permission before they even start this discussion. And I think that we could all really do some work on, if you're going to have a concern, you have to ask my permission first to have that conversation, and approaching it from that standpoint. I always think engaging in a conversation with anyone and hearing what they have to say and hoping that they will hear what we have to say, is how we all learn. And it's how we all work together. And I think it's okay to go into conversations with some rules, and that top rule of asking my permission and kind of controlling the conversation, I think, is a really important one. I think we can lean into it, and it's included in the documents. I also think, until it's replaced, going back to the 2016 American Academy of Pediatrics own commentary on preventing obesity and eating disorders, where it says, discourage dieting, don't, promote positive body image. I think it's okay for families to walk in and say, this is the tact I prefer to take. So I think these are, I think we can get a little stronger in using other parts of the literature ourselves.
Thank you. We're getting close to the end of our time, but I just want to ask one more question. Someone asked whether you can expand on the medications. Are they used to jumpstart or reduce cravings? And what studies have been done on them for the use of teens aged 12 to 17?
Yeah, so in the short version of the paper, the executive summary, there really is not a discussion of the medicines, of side effects, FDA approval, side effects, consequences, any of that. It really takes place in the full-length version of the article. There are many, many medicines they discussed, all of them with different targets and different side effects. It's kind of a discussion that's really beyond this, the scope of our conversation today. I think that my primary concern is that we have a paper out there that lists a bunch of medicines for providers to consider using in children. Like I said, it's quite an extensive section with a lot of different parts about what's FDA approved, what's not FDA approved, what age, what indications. So really I'd say beyond the scope, and almost too much to analyze quickly. I think the bigger thing is that they're recommending medicines, and that they listed any medicines at all in the full-length article is probably enough to even focus on, wrap our heads around at this point.
Great, thank you. So I would like to, first of all, thank you again so much, Dr. Tanner, for joining us today. This was a really important topic. You covered it really comprehensively. I see from some of the names that I recognize, there are providers here, there are parents here, which I love. I mean, that's one of FE.A.S.T's main principles, is the collaboration between all stakeholders. And we've really been able to do that here today. So thank you very much for that. I'd like to remind everyone about our upcoming Feast of Knowledge conference, which is taking place on February 26th. I'm sorry, I went out of order on the slides. So we have this amazing Feast of Knowledge conference. It is a 6-hour conference. It has amazing presenters, a wide variety of topics. Even if you're a provider, you can learn a lot. There are scholarships available for parents who can't afford the fees. Please take a look at our website and please register today. And as the previous slide said, we are only able to do programs like this without charging due to the generosity of our community. So if you're able to go to our donate page on our website and give something, we'll be able to continue offering programming like this free of charge and accessible to everyone. So again, thank you everyone so much for joining us today. Thank you again, Dr. Tanner, and I hope to see everyone at Feast of Knowledge later in this month.
Thanks for having me.
Bye.